All right, hello everyone. We'll let everyone have a few minutes to join the session here. And while we're doing that, we'll go ahead and make some introductions and do some of our housekeeping things. Many of you know this is our fifth year of doing our Fireside Chat with Dr. Pacak. And so we're excited to be 5 years into this. I changed our background up a little bit. It's not fireside, but it's snowy, Christmassy in the spirit. So hopefully that gives someone some joy. So thank you for joining us on this special edition. My name is Shonna Snyder, and I serve as a volunteer on the board as a volunteer on the board of directors for the Pheo Alliance. I am also one of Dr. Patsak's patients. And a little bit of my background, for those of you who don't know it, is I actually had a bladder paraganglioma. Took me several years to get diagnosed and went, sort of through a very typical journey where I had doctors who didn't think, they thought it was all in my head and I had anxiety. And so I had a similar journey that we hear often. I made my way through a long, kind of windy path. I made my way to the NIH and met Dr. Pacak, and he took me on as a patient. So I'm doing very well, 5 years out, no reoccurrence, and feeling very healthy. So I attribute a lot of that, most of that to him. So we'll talk more to him here in just a second. I'll introduce him. But let me go through again a little bit of housekeeping. So this program is brought to you by the Pheo Alliance, whose mission is to empower patients with pheochromocytoma or paraganglioma, their families, and medical professionals through advocacy, education, and a global community of support while helping to advance research that accelerates treatments and cures. So also a special thanks to our community for making this happen. I know we have a lot of people on the call today. We have a lot of questions to get through. We will try to get through as many of those questions as we possibly can. So thank you for your donations and your support over time. We really appreciate that. If you would like to stay in touch with the Pheo Alliance and our news, please sign up to receive our emails at pheopara.org. and follow us on social media at pheopara. Today our agenda will be entirely Q&A. Some of the questions have been submitted already submitted, but we will be monitoring the chat function. So if you'd like to submit your questions there, we will be monitoring those, and we will try to get to as many of those as we can as well. Sometimes there are variations to questions, but it's in essence, it's the same thing. So do pay attention. While I might not read your question specifically, like exactly how you stated it, I might still be asking about the same topic. So do pay attention. Your question could still be answered. It just may not sound exactly like you submitted it. Okay. We do try to answer more general questions and not specific cases. So if you do have a question that is about your specific case and it cannot be answered in a general matter, you can always email the Pheo Alliance and we can pass that on to one of our physicians, or you can email Dr. Pacak. He's very good at answering email. I always am afraid to volunteer him, but I know him very well, and he does get to a lot of emails and answers a lot of patients' questions. We love him for that. All right, so our disclaimer today is the information presented on this webinar is for educational purposes only and should not substitute the advice of your doctor and medical team because they have an in-depth knowledge of your specific medical history and your current situation. Okay, so let me introduce Dr. Pacak, and I'm actually going to give a shorter introduction today because Dr. Pacak has gone into a bit of a semi-retirement, so I'm going to let him give us an update on where he's at, what he's doing, and how he is working with Pheo patients and the community. So, but a little bit of background. Dr. Pacak has dedicated his entire career to providing the most cutting-edge clinical care and advancing research for PheoPara. He does serve as our PheoPara Alliance Medical Advisory Board Chair. And most recently, he was the chief of section at Medical Neuroendocrinology at the National Institute of Child Health and Human Development, which is one of the largest centers in the world to diagnose and treat patients with PheoPara. So I'm going to, having said that, having introduced Dr. Pacak, I'm going to allow him to give us an update on what's going on with him and where is he at. Dr. Pacak.
So thank you so much. So first of all, good evening, or over there would be actually maybe good morning and good afternoon. Here, in Europe, we have an evening. And first of all, I would like to thank PheoPara Alliance for very nice invitation. It's really great honor and pleasure, to be here today and to be with all of you. I also would like to thank Shonna for a very nice introduction. By the way, Shonna, I like your background over there, so related, or reminding us, pre-Christmas actually time. So as many of you know, actually, I left the NIH, and some of you ask a question maybe or thinking about why I left the NIH. I can tell you honestly, I was not the one who would be told to leave NIH. Actually, it was very complicated, very difficult decision for me. But because of my family, I finally decided actually to join my family because there was a long period of time, approximately 1 year or so. I was there by myself, and then finally I decided. And as I said, it was very complicated, very difficult. But I can promise you, that I did not abandon you, definitely not. And I will tell you why and what is happening. So number one, so thanks to NICHD leadership and especially, our directors, including our clinical director, Dr. Catherine Gordon, so we were able actually to keep pheochromocytoma and paraganglioma at the NIH, at the NICHD, the previous institute I was working, with, and I have a successor. The successor is Dr. Hussam Al-Kaisi, and I promised that I will be educating him as well as I will be the advisor. And that would definitely be, for period, at least, I would say 3+ years. So you will be seeing me, or I will be around, and I will be also coming to NIH. And when I am there, maybe some of you who will be coming to NIH, you will be seeing me. So, so that's number one. Number two, so we will keep, the same protocol. And because, I left actually about 2.5 months ago, so we are keeping the protocol on hold at the present time because, we have to go as a federal institution and with certain rules and guidelines that we have at NIH. So we have to go through certain arrangement, but the protocol is expected, to be open in a few months. I would say approximately in 5 months, the protocol 5-6 months later, so hopefully, will be reopened, and you will be definitely welcome to come. And I can tell you honestly that every week I am in touch with my group, with Dr. Al-Kaisi practically on daily basis, with my group. I would say, once or twice a week, and we go through patients because I have certain appointment with the NIH, it's called scientist emeritus. I'm not sure if I feel as an emeritus, to be honest with you, but, this is, what is happening. Also, I wanted to tell you that in Europe, I will be working as a medical director who will be focusing on adrenal tumors, including pheochromocytoma, paraganglioma. So we will be also welcoming patients not only from Europe, but from US. So if somebody would like to see me, and for example, you have a let's say trip, or travel, that sightseeing, you would like to see, Europe. Well, and I'm not talking only about the Czech Republic, but I'm talking about who would like to visit, some different country. And meanwhile, to see me, I will be very happy actually to see you and to talk to you and to help you, with the management. I'm located in Prague, and Prague is a wonderful city. So you can you hear that and you can see that I'm staying in the field. And the last actually information, which I think it's maybe also good for you, I'm trying to put something on the international level. I will not disclose it just now because working on that, and it will take maybe about, 2 3 months. But I think that you will welcome it, and because I think that we need, to put together, some other countries and learn, from others as well, but also patients who are, for example, complicated, difficult, to discuss those patients and put together, the best plans, because it's your health. It's your actually, I would say, life. And we want to help you. So I will definitely stay in the pheochromocytoma paraganglioma field, and I can promise you. And you will see also some very interesting publications, and some of them are related to treatment. And I think that, yes, some of you will be happy, seeing these publications, and also, seeing, that you will have some options, for maybe some additional treatments.
Yes, that is exciting to hear that you are working on really some bigger things, it sounds like, in the work. So that's very exciting, and we're all grateful to hear that you're not leaving us, you're still around, and if we want to make a fun trip to Europe, we can still see you.
Yeah, you can still see me, and also really feel free, to communicate with me as well. So if you have any question or something that you would like to discuss with me, I will be happy, to talk to you. And I am also staying in the position of the chair of Medical Advisory Board for Pheo Alliance. So I will be, I think, the one who will support, your care and your best outcome with your very complicated and rare disease, also through this organization, including, for example, some meeting or presentation at, I would say, at professional societies, where I will do my best to educate physicians about this disease. So less patients will be diagnosed late, or more patients will be diagnosed early and properly, and the treatment will be initiated, or well, they will be referred, to really good experts in pheoparaganglioma.
That's great news. That's great. So that sort of is a segue into the next kind of opening part that I want us to talk about today. And that is, so since we have done our last fireside chat last year, what are some of the new research, new guidelines, new treatments? Are there any new diagnostic tools? What's new? What's going on out there that we might want to know about that's new and that can really help patients?
So there is a lot of new, but, for the patients, and I understand, where your question is actually aiming to. So it's something that would be related to patients and would help patients. So first of all, so we are, or actually we finish, the first part of the study using radiotherapy with Lutathera. And of course, some of you and some patient would say, well, something is already known. Yes, I understand it is. However, the study is very unique, and this is the first study, if I take it as worldwide or globally, that is actually focusing on patients with progressive, metastatic or locally aggressive pheochromocytoma paraganglioma, because we wanted to know, how actually Lutathera, which means lutetium-177, combined with the dotatate, may work, for those patients, and whether those patients really need chemotherapy, or they could actually be treated, with radiotherapy, which is for most patients, I would say, much, much easier. And the data are extremely promising because the study has not been published yet. So I don't want to go, into details. But this study is very, very promising, has very good outcomes. So I think very soon you can actually expect that, the study will be published and the data will be definitely will support, your, I would say, consideration to have this treatment. Talking about the Lutathera, there is one more actually outcome from this study, which we believe, although we cannot influence so much, but but it will contribute to FDA approval of the Lutathera. And we are very much convinced that this is what's going to happen. Because as you know, US is one of some countries, I would not say few, but some countries where Lutathera, whatever the reason is approved for neuroendocrine tumors, but is not approved for pheochromocytoma, paraganglioma. Paradoxically, those tumors are also neuroendocrine tumors. So we will do all the best, to be approved. So many of you will not have difficult time with the insurance. There is another study that is planned at the NIH and will come, I think, next year, especially, under NCI leadership, that is very positive about the alpha therapy. And the alpha therapy is something also that is under radiotherapy umbrella, but is very, very good, very promising. The side effects are very minimal compared, for example, to Lutathera, that has, of course, some side effects. So, and we feel that alpha therapy will be another option. For the guidelines, I would like to say that we introduce several guidelines, especially for those patients who have complicated, problematic pheoparaganglioma. I just wanted to say that those are patients with succinate dehydrogenase, mutation like SDHD, especially because those patients, of course, are facing complicated scenario. Because, those tumors are usually, not always, but more aggressive, and those patients, develop metastatic disease. Then was the guidelines for SDHD. So patients who have pheoparaganglioma related either, to B, as I said before, or SDHD. And then finally, two another guidelines. One guideline is for children. Just remember that, there is a very good guideline that was initiated, especially with investigators from UK, Dr. Casey, Dr. Pampuraki, and we were part of this wonderful effort to put it together, for the first time for pediatric patients. So many of you will need actually to see it because you may have actually your children, suffering from pheoparaganglioma. And the last one is for carriers. Carriers means that those patients or subjects do not have pheoparaganglioma, but they have a mutation, and this mutation actually can lead to development of pheoparaganglioma. That was for carriers, also for succinate dehydrogenase, because we feel that this is one of the most important. Of course, patients have other mutations, but they are not so complicated, problematic, and usually we can work with those patients a little bit easier than those that they have a succinate dehydrogenase subunit, either A, B, C, D, mutations.
Yeah, yeah. Okay, well, those are great updates. And I think, again, that leads us into some questions that are related a little bit. So let's dig into a couple of these questions here. The first one is, how does immunotherapy distinguish between the healthy tissue in non-hereditary metastatic Pheo? So there's several things going on in that question.
Well, that's a little bit complicated actually questions, and so the immunotherapy, of course, so it's aiming towards, either to stimulate, certain cells, we call them T cells, that can actually destroy the tumor, and whether it's pheochromocytoma, paraganglioma, or other tumors. So it depends. But if I talk about immunotherapy, I mean, generally speaking, so of course, that even if you don't have, the specific target, you can actually unleash those cells, the T cells, that could actually destroy the tumor. But however, in those therapies where we are not actually creating special T cells, and I will talk about that, so of course, so those T cells can affect the normal tissue. This is why patients have, for example, some problem with the liver function. They can have a colitis, the inflammation that is sometimes, problematic, or they may have, for example, failure, of the thyroid gland, even adrenal, or, the pituitary. But there are also therapies that are using CAR T cells, and those are especially engineering cells, T cells. We are not there yet. I wish, we will be there, but you have to understand that to create the CAR T cells, you have to have a special antigen. For example, the Pheo paraganglioma cell, let's say, would have, special antigen. So it's the tumor-specific antigen. And if you know that antigen, you can create a special T cell. The T cell, is the one that is actually destroying the tumor. However, you have to put, the specific receptor that, it's like, I would say, key and lock, okay? So they have to, the key has to go into the lock and open, the lock. And this is exactly when you know the antigen, you can actually design the specific receptor, and then the specific receptor will be linked to that antigen. So therefore the tumor can be destroyed. So therefore, we know that normal tissue does not have that antigen, so there won't be, so many side effects. There always will be some side effects. It's a little bit more complicated. We don't have so much time to discuss that, but, that's also something to consider. But we are not there yet for CAR T cells. And then, of course, so the therapies that are other immunotherapies, like, to inject something in the tumor. Of course, some of you would say, well, how can we inject something in the tumor that will release catecholamines? It's not so complicated, because those needles that would be used in the future will be very tiny needles, and the patients will be blocked, so with the blockade, something about the alpha beta blockade, and I think that would be feasible. And that can be done even before operation, because operation is standard of care. So you have to keep the standard of care, but I think that there will be a room, to do something, before the operation, and to stimulate actually the immune system even before operation. And the idea is that once you stimulate the immune system, the T cells are actually activated, but also there are T cells that are memory cells, and they will actually memorize the tumor. Even the tumor is not there, because you remove the tumor and tumor will not be there, but doesn't matter because they already memorized. And those cells usually survive for approximately 15, 17 years plus minus. So which is very good. So once some cell will appear, that would be bad cell. Bad cell means, tumor cell. They can actually destroy that cell. So there are some, I would say, movements, to work on that. and to see, whether this concept may work. But if the concept would work, at least the preliminary studies are very, I would say, promising. I think that there will be another venue in immunotherapy, and there are many other ones.
Very good. Yeah, very exciting. And our immune system is very important, isn't it?
Yeah, absolutely. I think it's very strong, can destroy the tumors, very efficiently, but has to be, very well programmed, modified. And once it's programmed, modified, and at the right time, so it can be extremely powerful and work in favor of the patient to destroy the tumor or tumors or even metastatic lesions.
That's great. Along this line, how do you think AI might play into this? Do you think AI is
Well,
going to impact us?
Well, I would maybe switch, from the AI in combination with immunotherapy because that can be a little bit more challenging, complicated, and we have limited time. But, for example, AI may help. One example is radiology. Where several groups are working on to characterize some tumors, pheochromocytomas, paragangliomas, for example, in the adrenal gland. So patient is coming, has, for example, tumor or something, some nodule in the adrenal gland. Is it pheochromocytoma? Is this something else? So, and today the AI has very good actually programs and sophisticated tools, to be able to say, yes, what you have, for example, in the adrenal gland is maybe pheochromocytoma or it's not pheochromocytoma. Also, so many scientists just now are trying, when you have this nodule, for example, then to predict, whether this nodule, let's say it's pheochromocytoma in the adrenal gland, what is actually likelihood based on AI, we call, for example, we call it radiomics because, for example, you use the CT and MRI, you extract millions of information. You see, the with the eye, we see only very few, features, but AI, specific programs, they see, million, of these features, and they will put them together, and and scientists are trying to find out how they can predict, that, for example, the tumor, that pheochromocytoma, what is the likelihood to become metastatic. And I think that that would be wonderful. And I think it will come in the near future when, for example, CT and MRI will not only tell you about the size, about the location, maybe will tell you something about necrosis, etc., but will also tell you what is your likelihood that you may develop metastatic disease. And that's when this will happen, together maybe with other tools as well. I think that that would be marvelous. And can you imagine that if you have, this estimate, plus, for example, you will have genetic background. Even today, the radio mix are trying actually to predict what kind of mutation, what kind of genetic problem, genetic disorder you may have. I think we will be there. It's a matter of time, and I think that everything is moving very fast. So we will be there practically very, very soon. We have something at the NIH, but I know that also scientists, for example, in Italy, France, and in Asia, working, very heavily on those concepts. So if we put something together on the international level, and then a very huge number of patients and I would say the pictures, because you need as many pictures you have, then you can be more successful. And successful means that you will be more accurate and giving the patients better information how to use actually the AI or the results from AI in their favor.
That's exciting, very exciting. So what is your opinion? This is another question that came in. What is your opinion about cyberknife and protein beam radiation for these types of tumors in general, but this patient also wanted to know about vagal paras.
Yeah, so I think that it's a little bit, it's not protein, but it's proton beam radiation.
Proton,
And,
sorry.
so a cyberknife,
I didn't
so
read.
no, that's okay, so we are talking especially about head and neck paragangliomas. It's a little bit complicated or more complicated, to go below the neck. And the reason is, the data is limited. And I think that I would go back, to head and neck paragangliomas. Yes, for example, radiosurgery and overall, so it's a stereotactic, approach. Surgery is very good, for the head and neck paragangliomas. So patients, they have different options. Patients have, with head and neck paragangliomas, just not to do anything, and I will return to that. Or to have, for example, the radiotherapy, either conventional radiotherapy or stereotactic, radiosurgery, or they can have for example, the chemotherapy and or combination, for example, chemotherapy and surgery. Remember this, if you have head and neck paraganglioma, if you are a patient with head and neck paraganglioma, approximately 40%, and it really depends what you read, because there are some papers that they may have, a little bit higher percentage, but approximately 40% if the patient is coming to the clinic. So 40% of them, with the tumor, let's say the tumor is 3 centimeters or so it will not grow. Okay, so the question is, should I really, do, so to undergo the operation or not? Or because, most likely I have a 40% chance that the tumor will not grow. Of course, there are some patients that are more anxious and they will say, no matter what, it may, because of course, medicine is not mathematics, and they will say, to be removed. And of course, if it is, if the surgeons feel comfortable that the tumor may be removed, the tumor can be removed. So yes, that's one approach. And another approach, the surgery, you get specific radiation. You talk about the proton beam radiation, so you talk about the cyberknife. It depends of the location, size of the tumor, and everything, because there are specific indications. They are in the hands of radiation oncologists, and they can do it. The outcome, from those actually modalities are extremely, extremely good. And we don't have studies like, looking at, 15 years back, but we already have studies approximately 5-10 years, and the outcomes are very good. The stabilization is for many, many years. So the patient should not be afraid, that there would be, some progression. Of course, as I said, not everybody is the same, but the majority of the patients will do actually very well. If I go back to surgery, and I always say that, to my patients, yes, you can have surgery, definitely for carotid body tumors, that usually they are, not very, very big, over 5-6 centimeters, where that can be complicated, so they can have, the operation. And usually that would be with the good outcome. But for example, a vagal paraganglioma, because you mentioned something about vagal paraganglioma, I'm pretty sure we have some patients who had the operation. Well, I can tell you honestly, practically most patients, 99.9% of the patients will have actually consequences from the operation. If you don't mind that you will have a consequence from the operation, that can be, either temporary or permanent. It depends. And so you can actually consider that operation, but those operations are very difficult, very complicated, and even I am not surgeon, so I never recommended patient with vagal paraganglioma to be operated. Exception is if those tumors are growing very fast, very quickly, or after radiation or after chemotherapy, after surgery, there is some recurrent tumor growing again very quickly, that may be the operation to be considered. But most of you be careful. Even we have excellent surgeons and very experienced, but those vagal paraganglioma are always around the vagal nerve, and I cannot imagine that the vagal nerve would not be damaged. If there is any patient, today, and did not have vagal nerve damage, during this operation, please write me email. But I would like to learn about that. But as I said, consequences are problematic sometimes.
Yeah, understood. Surgery is always, there are always pros and cons. You always have to weigh,
Yeah.
all of your knowledge and then make the best decision for you with your doctors and
Yeah.
surgeons.
But for example, if you have a tympanic paraganglioma, that should be operated, for example. Okay. So the other side, what I said about, for example, vagal, tympanic paraganglioma should be operated. And usually, surgeons are extremely good, worldwide, and they can do, very, very good procedures. And this is one of the type of the tumor that is in the head, but, should be operated.
Okay. All right, our next question. How does the Dicer1 gene affect pheochromocytoma? So this person is actually asking about this specific gene, it seems like.
Well,
Dicer1?
so we did not have any, so much experience, with this gene. So I will most likely apologize. You are giving me, it's quite interesting question today.
Yeah, this was an interesting, I had not heard of this one. So this is a gene that's not on our radar with.
It's not so much, so on the, so not absolutely sure, what would be, the outcome, for the patients, here, for this gene.
Okay. Okay. Let's move to our next one then. How about iodine seed implantation? Have we heard of this? Any promise in iodine seed implantation for metastatic disease?
Well,
Is this another one we're haven't heard of yet?
another, complicated, so iodine implantation, I don't think that is, being done, at least not in the US, for the iodine implantation, because, we are using iodine, 131, for the therapy of, patients with locally aggressive or metastatic Pheo/paraganglioma. So I'm not absolutely sure what would be the advantage of the iodine implantation, here, unless, that would be, some, first of all, I don't know how it would be made and distributed. And also iodine need, some carrier, to get into the cells. It's not like having iodine and mix it with the tumor or tumor cells. You have to have something that will carry, iodine inside, those cells. And, that, the compound that is carrying iodine is, for example, the MIBG, methiodobenzoylguanidine, but it can be also fluorodopamine. that would carry actually through norepinephrine transport the system iodine inside the cell, and of course, we destroy the cell. So it's interesting question, but I don't think that I have enough information that this type of the therapy, just with iodine, could be successful for a patient with pheochromocytoma, because I have a hard time to imagine or to come up with good explanation how this iodine would get into the cells, into the pheochromocytoma cells.
Okay, so, all right, we're gonna keep going. Are there any updates on the progress of alpha PRRT? When will Belzutifan be available?
So the
those?
alpha PRRT, so it's in the process, there is actually the clinical trial, if I remember well, there is one in Texas, for alpha therapy. And there are some in different countries. Some very interesting results came from Israel, where they found, that the patients who were treated, for example, with Lutathera and fail actually the therapy, they were treated with alpha therapy and they had beautiful outcome, even that they fail, the Lutathera therapy. I think that the paper came a few years ago from Dr. Yadav and published, I think, Journal of Nuclear Medicine, or, one of the nuclear medicine journals. Doctor, just, I will come up with his name, in Texas, so he is with his team working on alpha therapy, and I think the results are promising. Whether they are working on, for example, neuroendocrine tumors or some other tumors, now I'm not absolutely sure, but they have some interesting results. And, at the NIH, the protocol is, I think that I was told by Dr. Lin, who is a DNCI, who is excellent investigator, nuclear medicine physician, as well as oncologist. So he actually, preparing or finishing the protocol for alpha therapy, not only for paraganglioma, especially those who, for example, fail Tatera, and also for patients with neuroendocrine tumors. So I think that you can expect sometime soon that, this alpha therapy will be available. And for those patients who are in the United States, hopefully you will be able to be treated not only outside the NIH, where, I cannot comment about, whether, there will be some cost or will be under, ongoing clinical trial, but the NIH, of course, would be under clinical trial, but will be without any cost. And I am positive. I am very positive about this therapy. I cannot wait, for the outcomes, and I feel that the outcomes will be good. And also there is something good, for alpha therapy. Can you imagine you as a patient come in the morning and you will be discharged in the afternoon, without any problems. You don't have to stay in the hospital. So that will be absolutely, everything will be wonderful. You practically will be traveling back, to your home, in the afternoon or in the evening, so I think that's, and the side effects, for example, like other ones have bone marrow, suppression, or they have, some other problems, will be, most likely, very, very limited. Of course, the first few patients will need to stay in the hospital, but to get, some experience, to get some very good view, because safety is the most important, for the patients. But if this will work well, and especially for the patient with high tumor burden and, for example, high catecholamine levels, I think that will be very promising, that the patient will be returned home the same day.
That is fantastic. And patients should be really excited to hear that news.
I think they should, and especially they will have another option, to be treated, even, for example, MIBG or, the Lutathera will fail and they will have some progression. So there will be another radiotherapy that would be very, very useful.
That's fantastic. All right, so we have another question. This question is, if a patient only has one extra-adrenal paraganglioma, so they have one paraganglioma at present, and they're having it removed, what's the likelihood that it will come back or a new one will appear in the future?
Yeah, so that's it's an interesting question, but the question it's broad because so it depends where the paraganglioma is located. I assume, for example, in the abdomen. Okay, so then it depends on the size. If the paraganglioma, the size of the tumor is approximately about 6 centimeters and up, you have a very high likelihood you will develop metastatic disease. I will be honest, with whoever, asked the question. If the paraganglioma has, certain type of a mutation, sometimes we say pathogenic variant these days, but let's keep, mutation because, people, our patients, they know actually this word. So if somebody has mutation, again, that is related to the gene, and then that is associated with more aggressive metastatic disease. So it's even worse, okay? And then, of course, it depends on the biochemical phenotype, for example, because those patients that they are producing, especially, for example, high amount of dopamine and especially its metabolite methoxytyramine, which unfortunately is still measured only at the NIH. Even I heard that there is some lab, maybe, somewhere in US, maybe Texas, California, I don't know. So those tumors are usually less differentiated, and if something is less differentiated, has, higher propensity, to metastasize. So it's a little bit difficult, to answer your question about, what is your likelihood, but I can tell you honestly, we are working on the application. Especially, with people from Germany, when we put, where the tumor is located, size of the tumor, genetic background, catecholamines, etc. And we can predict, what is actually likelihood for metastatic disease. Came from Dr. Pamparaki, Dr. Eisenhofer. They are excellent investigators, and they are working on the application. So maybe that application in some few years, because as you know, application is practically new device. So it's a little bit difficult, to go through all the steps, regulations and everything. But once everything is done and tested on additional groups of patients, I think that there will be application in your mobile phone, like other applications, and you will be able to put, those information by yourself, and then you will see, what is your likelihood, to get or to develop, I think, recurrence/metastatic disease.
Yeah, so it sounds like we're kind of working on almost like a little flow chart, like,
Yeah,
and you have this,
absolutely.
and you have this.
And then you put everything together, and then you press, just tell me, what is my likelihood, and that will be important because, you will show it to your doctor, and the doctor will actually personalize your follow-up, because we have the guidelines, and of course, guidelines are guidelines, but you have to understand that everybody is different. So if we will have this application in the future, that will be, those guidelines and everything what is there can be altered and should be altered, because nothing is absolutely, this is certain way, so we have to be flexible. We have to modify because you all are a little bit different. You all need a little bit, different approach. So this, for example, application, this app, so will be very important. But also, as we talk about, artificial intelligence, and it's coming. I think in 5 years from now, you will be very, very surprised what will be available. So if you show actually also the results, from your scan, whether it's CT, MRI, or PET scan, and you will tell your doctor, look here, based on that, this is, most likely my likelihood to have, for example, metastatic disease, or you will have a very low likelihood, and then, so you will not be exposed, for example, to radiation from the CT, or even, just, MRI or PET scan, so often. So, which I think also will be actually big plus because the radiation counts, and that from PET scan and CT you have some radiation, and of course it will offset your anxiety, nervousness, about that I can have, for example, or I can develop either a recurrent or metastatic disease.
Yes, that's excellent. And that also brings me to another question, which is how often should I get tested after I have had, an adrenalectomy or, certain tests. If after I've had one test, how long then do I get the next test? So how would you, kind of answer these questions that patients have about, how often do I get scans? How often do I get tested? What's kind of the answer
Yeah.
to that?
Again, the adrenalectomy depends, about the size of the tumor, the type of the tumor, biochemical phenotype, as well as genetic landscape of the tumor. But, my rule is that all the patients after surgery, whether it's adrenalectomy or whether it's the tumor is, for example, removed from the abdomen, from the chest, let's say is biochemically positive tumor at the beginning before the operation, that should repeat the biochemistry in approximately 8 weeks after surgery. And if the biochemistry, so it's negative, that most likely, your tumor was removed entirely, and you are at that time most likely, cure. Of course, cure is sometimes a little bit strong word, but anyway, if everything is negative, most likely everything was removed very successfully, and this is a very good, to be done. I usually suggest approximately 8 weeks, 6, 8 weeks, when you are in good condition, you don't have any pain, you are just doing well, like, before the operation, or even better because, the catecholamines are not elevated. I also suggest for, the better accuracy and for also to have I would say to be convinced that that the tumor was removed entirely. So I would suggest 3 months after operation, to do the scan. I would not most likely do it earlier because there are postoperative changes. So between 3 and 6 months, to do the scan. If the catecholamines, for example, and metanephrines that were elevated before the operation, will be normal. So 3 to 6 months, make sure that everything is fine. There is no anything, there left. Because, even if catecholamines slash metanephrines, although we prefer metanephrines these days, but let's say, still keeping, the both catecholamines, metanephrines, they are normal, you still can have the tumor less than 1 centimeter there, so remaining tumor. So I would actually do the imaging between 3 to 6 months. And if everything is fine, this is your baseline. This is your baseline, post-operative baseline, and you go from that baseline, and then you see, how to put everything together. Usually the doctor will tell you to repeat the biochemistry on a yearly basis. And the imaging, it depends on the type of mutation, but let's say sometimes approximately every 2, 3 years. Okay. So, but keeping in mind, that repeated especially metanephrines there in that case, later on, because they are, of course, better than catecholamines, must be repeated on a yearly basis. And that's key. If after operation metanephrine/catecholamines are positive, you need definitely another imaging studies as soon as possible or in the reasonable time. Let's say, maximum, I would say 3 months, and then to see, what remained there and whether you need to be reoperated or what actually happened.
Okay, very good. I'm looking for our next question here. How likely, well, this might be a tough one. How likely will SDHD familiar paragangliomas grow or emerge in an older female? This person is 80 years old. So how likely would SDHD familiar paragangliomas grow? I think what they're asking is if you have SDHD and you're older, are you more likely to maybe have new paragangliomas come up? I think that's what they're
Yeah.
asking.
Yeah, I see. I understand, the study are not there, especially at that age, so it's and it depends whether, paraganglioma was removed or not. Let's assume here, if I understood everything well, that the paraganglioma is there, the person is older, is there any accelerated growth in older age compared to those individuals that are younger? Well, on one side, I would say yes, and the reason is because immune system is becoming weaker when we age. And of course, immune system is very important. So I would have an inclination, that this tumor will be, may grow a little bit faster. However, in children, we also know that some tumors are growing, pretty fast, and that can be aggressive. So I think that there are a lot of factors that are actually around, and it depends, where the tumor is located, what is the biochemical phenotype of the tumor, and of course, what is the genetics behind, this tumor. I am afraid that I cannot give you exactly the numbers here, so because I don't think that those numbers are known. But we know, for example, that in older patients, if the tumor is removed and they develop metastatic disease, the interval from actually when the tumor is removed and then, when they develop metastatic disease, and maybe also in the patients who had partial removal of the tumor or did not have removal, but I cannot of the tumor, but I cannot say for sure for the third category, that the interval to develop metastatic disease is definitely shorter than for those who are, for example, younger, middle age, or even younger. And I would say that it might be related also to weaker immune system, but then maybe another factors that are playing a very important role.
So age, as we age, our immune systems just in general do become weaker.
Exactly. Yeah.
So
This
yeah,
is why, most patients who get cancer are those patients who are older, yeah? You
right.
know,
Yeah,
so yes, kids, they have a cancer, middle age, population, individuals have cancer, and we know about that, but the most cancers are coming, after the age 60 plus,
right,
okay?
right, right.
Mm, yeah.
Okay, our next question, are there any treatments or options to open abdominal surgery for a recurrent retroperitoneal paraganglioma?
So if I understand well, the question is about the open surgery.
I think so. Mm-hmm.
Yeah, so Yeah, you would like me to be surgeon, and so I don't want to comment and talk on behalf of surgeons who are expert in paraganglioma because they are really very good, and many of them I value very highly. But I would say that yes, we had, patients who had, for example, a laparoscopic procedure, and then, either it was switched, to open surgery, or, that later on we found, that there was, some remaining tumor, or even, something came back. So the open surgery is usually indicated for patients who have a big pheochromocytoma slash paraganglioma. Also for patients where when surgeons feel that those tumors are, for example, close to the vessels, and there will be during the removal of these tumors, it would be very problematic, as well as that can the damage certain vessels that can be very tragic and or very severe, the bleeding also for the tumors that are close to certain organs, so which is very important. And so definitely in those situations will be something that is needed actually to be considered. So and there are some other indications as well. For example, the anatomic distortion, whether because of previous operation or because some anatomic problem that the person was born with. And as I said, the size of the tumor, so even sometimes you hear that even tumors 10 centimeter can be removed laparoscopically. I doubt, but as I said, I am not surgeon. Yes, there are some tumors that can be, but for these tumors, you have to be careful. And usually for tumors 6 centimeter and up, the surgeons are considering, to perform, the open surgery. Again, I'm not surgeon. I don't want to talk on behalf of my colleagues, but overall, these are the rules when we are thinking, how, the operation or what kind of the type of the operation should be considered in the patient.
Okay. The next question is about safety considerations when doing an embolization for a carotid body paraganglioma. So can you kind of talk about that a little bit? And I am just going to assume that this patient probably has one of these, and they're trying to decide, like, do I do a surgery? Do I do an embolization? I'm assuming
Oh, I
that's
see,
what we'll talk about.
embolization. Yeah, so it depends, so the tumors that are small tumors, for example, 1 to 2 centimeter, there is no reason, for the embolization. Usually, patients can be operated without embolization. We hardly do the embolization, or did, because, I am not anymore at the NIH. But, hardly embolization, for these tumors when they were small tumors, and our surgeon felt that the tumors can be easily removed, in the classic, location for carotid body paraganglioma. It's those tumors that are, large tumors, of course, so I will need, to be considered for embolization, because, those tumors are vascular, and, that can be, the problematic when they are removed in terms of bleeding. Also, embolization can lead, to a little bit, I would say, shrinkage of the tumor. It really depends. So when the surgeons feel that, some shrinkage would be even, plus, they could also consider, the embolization. But it really depends, from one person to another. And the good experienced surgeon, will be always commenting about whether embolization is needed before, the surgical procedure. But I can tell you honestly, the small tumors, they don't, we usually did not perform any embolization. Patient went straightforward to operational room, the tumor to be removed, especially for carotid body. For, of course, for example, jugular paraganglioma, you always do practically embolization because, those tumors are very problematic. So it depends also where the tumor is located. But for carotid body paragangliomas, we very often go by the size and the position of the tumor.
Okay. All right, we're going to try to get a couple more in here. We're getting close to our time. Do certain mutations, for example, maybe SDHB, have higher likelihood of a biochemically silent Pheo?
Oh yeah, sure. So those are usually related to succinate dehydrogenase. Whether you are talking about ABCD, ABCD means there are subunits ABCD. So those tumors, they're approximately 5%. Some literature, I would say, describe 10%. I don't believe it so much, but at least based on the patients we had at the NIH, but I would say, maximum will be approximately, 5% of these patients, and they can have a biochemically silent tumors. They are a little bit more complicated, challenging. The reason is that, first of all, you will do not discover them early enough because, patient will not have any symptoms and signs related to catecholamine excess. So you will most likely present to the physician with pain in the abdomen, pain somewhere else, but abdomen is, the most common site here. And, but the tumors will be already bigger or even, big. So everything is a little bit more complicated. And the second, if you are having tumor that is biochemically silent, so does not actually, let's say, produce catecholamines, those tumors are or are considered still until today as less differentiated tumors. And whatever is less differentiated is more problematic in terms of, more aggressive behavior, including metastatic disease.
Okay. Okay. So
And
if
the only, by the way, the only, I would say, let's say the patient knows those patients with biochemically silent tumors, they know that they may have tumor because, for example, in the family was somebody, had, the pheochromocytoma, paraganglioma, they are afraid that they may have something, and they feel that there may be, some biochemically silent, although because they sometimes have a pain and they don't want to go, let's say, this is a little bit stretch, but, they don't want to go through imaging. One option would be, to measure chromogranin A, so because the chromogranin A, will not be dependent on the production of the catecholamines, so, and can show or, to point towards the presence of the tumor when actually the patient must go through imaging studies. Of course, this situation is a little bit awkward because usually it does not happen. But, so I'm thinking about something that, for example, patient would not like to go through imaging, but still would prefer, the biochemical test. So the biochemical test that would actually supplement, the catecholamines/metanephrines would be, or methoxytyramine would be the chromogranin A.
okay, that's a very good suggestion for those patients that are listening. Another question that this same person asked, which I think it's really a good question, is how is tumor size related to the strength of the catecholamine signal in the blood?
Yeah,
So, when you go in and get your labs.
Yeah, so tumor size is related in certain way, but there are great papers, from Dr. Eisenhofer, who is really excellent expert in the biochemistry of pheochromocytoma/paraganglioma, and he found with his teams that really catecholamines do not reflect well the size of the tumor. So if you would like to know something more about the size of the tumor or estimate what could be the size of the tumor, that you have to have the measurement of metanephrines. Okay, so this is very, very important. So not catecholamines, because you may have, catecholamines not really very highly elevated, and you can have a big tumor and vice versa. So don't go by catecholamines, but the metanephrines. Metanephrines will be more accurate, and there are some nomograms and everything to look at that and see or estimate what could be the size of the tumor.
All right. How are we doing on time? We can do maybe one or two more, and then we're
One or
gonna.
two questions we can go through. Yes, of
Okay,
course.
okay. Let's see. I have so many that I don't know which ones I want to pick. What are the effects of long-term exposure to elevated catecholamines on the cardiovascular system? What sorts of issues or damage does it cause? And will that resolve after we remove the tumor?
Yeah, so you pick up the question that we would spend, a lot of time, So consider, yeah, I would do, some comparison with high blood pressure. Everybody knows what is, high blood pressure, hypertension. So imagine, and everyone who is, on this webinar know somebody, who has a high blood pressure, and what the consequences are. The same consequences will be, with the pheochromocytoma, paraganglioma. On the top of that, the patient with high blood pressure sometimes do not have, palpitations, or heart is not beating fast. So for pheoparaganglioma, it's not only high blood pressure, but also the heart rate that is usually accelerated. And can you imagine that your heart, supposed to have, 70, 80 beats per minute, and will have, for example, 9100 every second, every minute, every hour. Can you, if you calculate how many actually beats you will have during the
Yeah.
day and during the week and during the, it's like the pump. And can you imagine if you have a pump on your garden, and you will be still pumping, 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 so compared to, that you will be pumping, slowly, or, you will be gentle, so it's with your water pump, so definitely damage is there. Catecholamines can also be released suddenly, and can cause, hypertensive crisis, myocardial infarction, stroke, but also aseptic necrosis of the heart, which is especially myocard, that it can be very complicated because it can go to myocarditis, aseptic, or cardiomyopathy on the long term, or, even, some we call it Takotsubo cardiomyopathy, that, the left ventricle and the apex, is not working, properly. I don't want to go into details, how it looks like balloon, but, so it's not working. So the consequences are tremendous. And I'm not even talking about ischemia, long-term ischemia, even maybe sometimes mild ischemia of the colon, intestine, kidneys, etc. So that is also, very problematic. So overall, there is definitely very deleterious effect of a harmful effect of catecholamines on long period of time if they are elevated. This is why we are telling our patients, if everything is indicated and they can go through surgery, not everyone can have a surgery, but if they can have a surgery, so to go through surgery, and if not, to use the proper blockade, to offset, not fully, because you never will fully offset the negative effect of catecholamines, but at least partially.
Everything you can to reduce it, right?
Yeah, you can reduce it, but
The sun is chasing me over
you will
here, so
definitely
I'm trying to stay out of the sun.
Yeah, yeah.
I
So
picked the sunny location.
I see. So, but as I said, you will not eliminate it fully, but you can eliminate, partially. And also, you should be aware that catecholamines affect glucose. Glucose will be elevated. You will have like pre-diabetes or diabetes. You know what the consequences from diabetes are. So there are many consequences from catecholamines.
Yes. Well, Dr. Potsdok, we want to thank you for your time today. I know there are several questions that we probably did not get to, and I will I believe that your contact information is out on the web, so people can find you and they can find your email if they need to send you a personal email with a question. And of course, we're videoing this, so anyone who didn't get to come live, they can go back and watch it again. But we want to thank you for your time and your dedication to our patient community. Special thanks to everyone who attended and who helped make this webinar series possible. We Pheo Alliance is able to continue because of everyone's support, and we appreciate that. We are holding our end of year giving campaign right now. So we recommend, if you are able to donate to your favorite charity, the Pheo Alliance. And you can do that on our website. And there's a donate button that you can go to. So please give before the end of the year if you're able. Sign up for our e-news, follow us on social media at Pheo, and give us a couple of days and we'll have this website up on our YouTube channel. And on our website, it will also be transcribed, and the Q&A portion is going to have that available as well. So thank you to everyone who attended today. And we know that we're going to continue doing these because I think it's really great for our patient community. So thank you again, Dr. Potsdok. We appreciate it.
Yeah. So thank you so much as well. I would like to thank the Pheo Alliance again, of course, Shonna, for moderating, this very interesting, discussion. I have to say that it seems to me, because I did it, several times, patients are more and more knowledgeable because the questions are becoming harder and harder,
I
so
agree.
congratulate to our patients as well, but that's good, because knowledge makes you stronger. And more it's better. So I very much, appreciate how patients are involved and how much they know about their disease. I also would like to say that my NIH email is still there and will be there for definitely long period of time. So you can contact me through NIH email. The same as before, or you can contact me, through my another email on my Yahoo. So, and I will be definitely happy, to communicate with you and to help you, with some questions that you may have, because of what I understood that we were not able, to answer other questions because this is how it is. But at least I hope that you got, some good information, especially some novel information, what is happening in the field of pheochromocytoma, paraganglioma. Finally, I would like to wish all of you, so very Merry Christmas, Happy New Year. Be very well. Enjoy, everything around the Christmas. Also much happiness. But if I would wish you only, or if I would be asked, to wish you or to give you one wish, that would be, good health or stable health, and because I think that is the most important. And again, it was really great pleasure, honor, to be with you, and I hope that I will be in touch with you and in contact with you and with other organizations, including Pheo Alliance in the future. So once again, thank you so much from my heart.
And Merry Christmas, Happy New Year to you as well. And we will see you next year. Thank you.
Thank you. Thank you. Take care. Bye-bye.
Bye, everyone.